Hello. Good evening, students. Good evening. From where we are streaming, we'll just check whether we are live or not. Just verify that. From where we are streaming, there'll be a lag of also some time. So can you just tell me whether am I audible to all of you and am I visible to all of you? Are we live? Yeah, I think we are. Yeah. Okay, we are live. Can I also get something in the chat box? Yeah, I think we are. Yeah. Okay, we are live. Can I also get something in the chat box? Okay, so welcome all of you to our session. We'll just get started for the must know MCQs. Is the audio video all? Yes. Okay, thank you all of you. Thank you. Yes, I can see Gaurav Verma, Kapil Patel, Samir. Yeah, all of you, thank you for coming in today. So we are here to discuss one of the must know MCQs for the upcoming FMGE examination. I would say must know FMGE topics. Just a couple of things before we begin. Unacademy, NEET, PG, all of you are aware. Rao sir, 1 hour. Okay, 5 to 6. We're going to discuss lots of MCQs. You will love the session. Okay. Just a couple of information before we begin. Very important. This is the NEET PG Vitals, where it is a complete studio recording of the lectures, which is by the best teachers. More than 800 hours of lectures, image based, IPQ, everything. It will be covered for all of you. So this is very important. Please go out and check. And the code remains mentor, MENTOR, mentor code, to get the discounts. Also very important, I would like all of you to go and give the All India AIMT examination for the FMG. This is up to 100% score. This on 25th of June in the morning, 11 a.m. Okay, so 25th of June morning, 11 a.m. please go and give the examination, free for all. And also the FMG test series is available at very discounted price of only 1900, and mentor remains the code to get that also. Okay, and then we have this ACE NEXT batch, which we are a part of. It just started today, and all of you were there today for the class that was on the Unacademy portal. That is the mentor thing. And FMGE also July, now available. Only 1.5 month short duration course is also available. Okay, so with this we would begin our discussion, and lots of hundreds of learners have got their this with the help of Unacademy. Let us begin our discussion. Special class features, all of you know. Interactive classes, polls, raise the hand anytime, anywhere, all that is available. Okay, so let us, and so all for all the codes, mentor is the code to get your discounts. Okay, so with this as the background, let us start on to one of the, these are all the very popular hot topics based on which you would get MCQs. Okay, so whether it's FMG or this also. So question number 1 for the day: Fothergill's repair associated with all of the following complications except. Anybody? I want you to answer in the chat box. Okay, Dr. 2, Dr. 1, yeah, okay, change your, okay, yes. So can anybody tell me Fothergill's operation is for which? Love Pandebi, no. Okay, Fothergill's operation is a surgery done for which condition? 2211. Okay, so anybody, what is Fothergill's surgery? Very important. And for which condition we are going to do it? Okay, so anybody. So Fothergill's surgery is done for prolapse, but specifically young patients of prolapse. Okay, young patients of prolapse. Now it is very rarely done nowadays because there are a lot of complications. Okay, so hardly ever, very good Vihari. Okay, so it is hardly ever done whenever I have got a young patient of prolapse. Yes, Dhwani also correct. Yes, so but specifically young patients of prolapse because I want to preserve the uterus. Okay, preserve the uterus. Now can anybody tell me what is the most important step in this Fothergill operation? So the most important step in this Fothergill operation is cervical amputation. Cervical amputation means I go and I chop off the cervix. And when I chop off the cervix, what complication can happen? Anybody? When we chop off the cervix, what complication can happen? So sir, when I chop off the cervix, what complication can happen? Cervical incompetence. That is the main danger. And we teach you in obstetrics what can cervical incompetence cause. Or the cervix can become too tight and there could be cervical stenosis. So sir, either the cervix becomes too tight, which is called as cervical stenosis, or the cervix becomes too loose, which is called as cervical incompetence. And can anybody tell me 100% FMGE where this question comes? It's a whenever there is a cervical incompetence, what it would lead to? It would lead to abortion in the second trimester and never in the first trimester. Very good, Parvati, and this one. Okay, so your answer is that first, it can cause preterm labor, it can cause cervical incompetence, it can cause cervical factor infertility stenosis, and cervical dystocia, all of you, means that during labor the cervix does not dilate. Okay, when the cervix does not, okay, so I'll just explain to you the meaning. When the cervix does not dilate in spite of contractions, it is called as cervical dystocia. So the answer is first trimester abortions, because first trimester abortion, most of the time the causes are genetic. Is this understood to all of you? So clap if you have learned something new. I repeat, sir, Fothergill operation, and therefore it's very rarely done nowadays. I repeat, Fothergill operation, main step cervical amputation, which leads to cervical incompetence, which would lead to painless mid trimester abortion. Okay, it causes mainly painless abortion in the second trimester, and therefore the answer is not this first, it is a second trimester abortion. Okay, cervix does not dilate, that is cervical dystocia. Is this understood? First trimester, by the way, can anybody tell me what is the most common cause of first trimester abortion? First trimester abortion, what are the causes for first trimester abortion? Yes, genetic causes. When it's survival of the fetus, genetic causes or your chromosomal defects in the baby, they are very good, chromosomal and genetic. So let's go on to the next question for all of us. Yes, now again please choose very correct. This is a new type of a question. Yes, very good, Dr. Anik Pandya, trisomies and very good, monosomy. Yes, serum levels of CA125 is raised in which of the conditions? 4 conditions are given to you and your option starts from here. Select the answer using the code given below. So this kind of questions can also be asked to you in your exam. Please don't make a mistake in this. So will I choose 1 and 2 only? Will I choose two and 3 only? Will I choose 1, 2, 3, 4, 1, 2, 3? C, D, A, D, C. Okay, yes. So point number 1, CA125 is it's a tumor marker, but all of you need to remember it is non-specific. Why am I saying it is non-specific? Because it is elevated in many conditions. Of course, the main, it's a tumor marker for epithelial ovarian cancer, so it is going to be elevated, but it is also going to be elevated in endometriosis, PID, as well as genital tuberculosis. So 1, 2, 3 and 4, those who said option C, okay, 1, 2, 3, 4, all means all of the above CA 125 is elevated. And I'll teach you something new also. CA 125 is elevated also sometimes, very rarely even in fibroids, very rarely even with fibroids also, and any other condition, students. So it's a very non-specific. Any organ of the abdomen you take, from here to here, any organ of the abdomen you take, any abdominal or pelvic organ I will take of your choice, and if I add ITIS to it, also CA 125 will be elevated. ठोको ताली. इसका मतलब क्या है? Appendix, appendicitis, peritonitis, salpingitis, gastritis, pancreatitis, all this, any organ you can choose. Choose say fallopian tube, so salpingitis. Choose say liver, hepatitis. Choose say uterus, so endometritis. Okay, so it's a very pancreas, pancreatitis. Is this understood? So inflammation of any pelvic organ. I hope you have understood it. Give me a thumbs up in the chat box if you love it. So all these cases, I repeat, mainly epithelial ovarian cancer, endometriosis, PID, that is a salpingitis, tubes, okay, including our appendicitis also. So it's a very non-specific marker which is which can be elevated in all the conditions. So CA 125 levels elevated in epithelial cancer, endometriosis, PID, genital TB, all, therefore 1, 2, 3 and 4. I hope it is absolutely crystal clear. Very good. Moving on to the next, again a hot favorite topic. I did not overemphasize. Dual marker test includes what? And can anybody tell me this is a test for what? What is the dual marker test for? What is it a test for? So sir, dual marker test is a screening test that we should know. It is a screening test for trisomy 21, Down syndrome. Can anybody tell me when is it done? If I ask you one more MCQ, triple dual marker test, 6 to 8 weeks, 11 to 13 weeks, 16 to 18 weeks, 20 to 22 weeks. Chalo, if I ask you one more MCQ, A, B, C, D, when to do dual marker test? Very good. Vihari, Priyanka, Samir, all of you correct. All of you. Disha. I might not be able to take everybody's name. Superb, excellent, sir. Super chat. Okay. So 11 to 13 weeks is the answer. It is done in the first trimester, 11 to 13 weeks. 16 to 18 weeks, I do which test, all of you? 16 to 18 weeks, sir, I do a triple marker test or a quadruple marker test. Okay. I hope that's absolutely crystal clear to all of you. So 16 to 18 weeks we can do, or we would do, a triple marker test or a quadruple marker test. Keep this in mind. 11 to 13 is answer. And what are the two markers what we do? Do I do HCG and alpha fetoprotein? No, HCG is correct but not alpha fetoprotein. Anybody? Inhibin A is a part of quad test. Very good. All those who said option number 3, it is correct. It is HCG and PAP A. Very good. Now one more thing, when the baby is supposed to be abnormal or having Down syndrome, HCG is higher than normal and PAP A is lesser than normal. This also we should know. Okay, so please keep this point in mind. That's why when the HCG levels are higher than normal, PAP A levels are lesser than normal, that is then the baby may have Down syndrome. It's a screening test for trisomy 21. Of course, I need to confirm it. I need to confirm it because it's only a screening test. One more point, can anybody tell me how do I do screening with the help of ultrasonography? Can anybody tell me ultrasonography test for Down syndrome? Chalo, so we not only discuss one MCQ, we discuss lots of MCQs with this. Very good, Dr. Samir Sahil Thakur. We do the NT scan and we do also NB, nasal bone. But NT scan is the answer. NT scan again tells me about trisomy 21. Okay, so please keep all these points in mind. It's a screening for Down syndrome by doing ultrasonography. Okay, let's move on to the next question. Yes, very tricky. Students get confused. Missed abortion is what? What is the meaning of missed abortion? Very good, Samir. Yoga. Yes. So point number one, what is the meaning of missed abortion? Missed abortion happens in the first trimester. Okay, what happens is that, sir, in a early pregnancy, it's a early pregnancy, but the baby heartbeat stops beating. The heartbeat either does not start or the heartbeat starts and it stops. So it is like called as a early fetal demise. We don't use the word IUFD. IUFD is used in the last trimester. It's a early fetal demise. Very good. It happens in the first trimester. But this dead baby is still retained inside. It's not yet expelled out. Okay. So what can happen is uterus stops growing. There could be some bleeding. It could be vaginal bleeding, fresh red or brownish in color. Of course, because uterus stops growing, uterus is smaller than weeks of gestation. I told you that the dead baby is still retained inside, so the os is also closed. But when not diagnosed, of course, when I see the baby heartbeat, this is normal. Isn't it normal? If the USG shows fetal cardiac activity, it is a healthy, normal pregnancy. Then how can I call it an abortion? So in miscarriage, in miscarriage or in missed abortion, we would have the heartbeat absent, early fetal demise. So fetal cardiac activity, as it is called, is absent. Okay, fetal cardiac activity is absent. That is what it is. Okay, so please keep in mind this is the answer. Now can anybody tell me one more important point? Can anybody tell me what is the difference between, because the students have a doubt, what is the difference between threatened abortion, main difference, threatened abortion and inevitable abortion? Lot of confusion among the students. So I'll clear it. Anybody? Threatened abortion, inevitable abortion. What's the difference? Threat of abortion. Okay, Sahil, very good. So what it is? Okay, bleeding. Yes, very good, Nikita Yadav. Okay, sir, in both, in the threatened abortion as well as there's only threat, bleeding will be present, but here the baby is alive, fetal cardiac activity is present, but most important, the os, internal os is closed. Internal os is closed. But when I say inevitable, matlab it is bound to happen, hone hi wala hai. Yes, inevitable is like irreversible. The damage is done, it cannot be reversed. So here the os is open and the pregnancy cannot continue. The os is open and the pregnancy cannot continue. That is the meaning of inevitable abortion. Okay, so please keep all this in mind also. Very, very important topic, vacuum or ventouse. Indications as well as prerequisites for ventouse delivery. Ventouse is also another word for vacuum. Include all except Okay, Abhishek Malhotra saying 3, Priyank Prakhar Tiwari C, Dr. 2 Samir. Yes. So point number 1, we are asking for either indications of prerequisites, all except. So of course, when I apply a vacuum, it has to be a vertex presentation. Okay, I cannot apply it on face, eyeballs will pop out, but I cannot apply it on the breech. I can only see the baby's bum. I can apply the vacuum. So head, it has to be a head delivery. So again, clap if you feel happy. How I tell all my students: V for vacuum, V for vertex. Okay, V for vacuum, V for vertex. That is how you remember. That's sir, vacuum is only for vertex presentation. And when can I apply it? So the mother is pushing and there is a prolonged second stage of labor, 2 hours, 3 hours, 4 hours, baby is not getting out, prolonged second stage. Or if there is fetal distress, the baby heart rate is dropping down, or if there's a maternal exhaustion. Okay, but can anybody tell me prematurity is a absolute contraindication? Anybody? Why? Prematurity, yes, very good in heart disease patients to cut short second stage. Okay, I want to cut short the second stage. Can anybody tell me why prematurity is a? Because sir, preterm babies are more prone to intraventricular hemorrhage. Prematurity is a absolute contraindication for vacuum. There is increased risk of intraventricular hemorrhage. Is this understood to all of you? Yes, forceps you can use in premature babies, like if it's a 34-35 weeks and interplay, so 34 weeks the cutoff. So here that is the answer. That's a delay in the second stage of labor. Yes. Non-reassuring fetal heart rate, that is what I told you. Fetal distress, non-reassuring means not good. So that is indicating of fetal distress. So that also I can apply, and of course it has to be vertex. Answer is option number C or 3. Gestational age cannot be less than 34 weeks because that will lead to intraventricular hemorrhage. Is this understood to all of you? So remember students, that when we have prematurity, it is a absolute contraindication for vacuum. Okay, prematurity. So keep that in mind. Okay, so please keep that in mind, that prematurity is absolute contraindication. Okay, yes. Now a very simple MCQ, definitely asked whenever there's max self is a very hot topic. There'll be one more MCQ also regarding max self. Very simple one. This is that when I use Pritchard regime, what is the therapeutic range of magnesium sulfate to be achieved? Yes. So all of you have to by heart these values: 4 to 7 milli equivalents per liter. At this range the convulsion stops. And can anybody tell me what is the total loading dose with Pritchard regime which I give? How much Maxwell do we give? We give it for eclampsia as well as if it's impending eclampsia. And what all 3 things do you monitor when the patient is on magnesium sulfate? What 3 things you monitor when the patient is on magnesium sulfate? We monitor the deep tendon reflexes or the knee jerks, we monitor the respiratory rate, and we monitor the urine output. How much should be the urine output? So urine output should be at least 25 to 30 cc per hour. Very good. And of course magnesium sulfate oxide, all that happens. And nobody told me the loading dose, remember students, is 14 grams. Little we will discuss in our actual classes, so please be there present for the actual eclampsia, pre-eclampsia class. 14 grams is the total dose. How to give, all that will teach you in detail. And also magnesium sulfate toxicity is a very popular MCQ. Yes. Now this is again a kind of question which has started coming in the FMGE exam also, as well as NEET PG, the sequence of events. So can anybody tell me what is the right sequence of events during normal labor or normal delivery. There are 4 events mentioned: engagement, restitution, external rotation, crowning. What happens in what sequence? Yes. So point number 1, the baby is in an attitude of flexion, descent, and the head will get engaged. So engagement, what is engagement? In the baby's head, when the biparietal diameter crosses the pelvic inlet, that is the first thing to happen. So engagement जो 1 है has to be 1. So automatically only this and this is ruled out. Don't you agree with me? Only these two are there, 50-50. Then what happens after engagement? Can anybody tell me? What's the next step? It's not mentioned over here. What happens after engagement? The baby's head touches the pelvic floor and there is internal rotation. Internal rotation will take place. No, correct. Crowning, yes. No, lightning is before. Lightning is pre-labor event. Lightning is when the baby is at this. Engagement will cause lightning phenomenon. Correct. A very good, Sahil Thakur. Internal rotation ke baad there is crowning. Crowning means the baby head is visible at the introitus, and then the baby head will get delivered by, head is flexed, so then there is head delivery by extension. Head delivery will take place. So crowning followed by head delivery. How does the head delivery take place? Head delivery will take place by extension. Then there is, what is the meaning of restitution? Can anybody tell me? Yes. So all of you correct. Option B is the answer. 1, 4, 2, 3. What is restitution? What is restitution? Restitution is the untwisting, because when there is an internal rotation, there is a twist on the baby's neck. So it is untwisting of the neck. Is this crystal clear to all of you? Untwisting of the neck. Okay. So head delivery by extension followed by restitution, and then there is actually internal rotation of shoulders, which is manifested as external rotation of the fetal head. What is external rotation? So it's actually nothing but internal rotation of shoulders. So this is a very, very important sequence of events. Please keep all this in mind. I repeat, engagement, okay, there is going to be engagement of the baby's head followed by internal rotation, crowning, head delivery by extension, restitution, and finally it is internal rotation of shoulders, which is manifested as external rotation of the fetal head. Okay, that is great, and it's very, very important. So I hope all of you have got this correct. Again, a very, very popular topic, surely asked to you in your exam. We have got a 16-year-old patient who has come to us with primary amenorrhea. Okay, look at the breast examination. Breast development is present. Absence of axillary and pubic hair, and USG uterus not seen. Why is the uterus not seen? Because uterus of course absent. So can you tell me what happens when there is absent? What are the only two possibilities? When I have a combination of primary amenorrhea along with absent uterus, what are the only two options, students? Some are saying C, some are saying A. No, why is it not A? Why is it not A? We'll tell you the MCQ in a minute. Why is it not A? I'll discuss, okay? Very good, Sakshi Singh Patel. Very good. That's sir and all of you, Vihari and Samir and yes Priyanka. It's sir, whenever is primary one absent uterus, so either it is RMKH, Rokitansky Mayer Kushner Hauser, or it is your complete androgen insensitivity syndrome. These are the only two things, and therefore both of them the breast is well developed. In both of them the breast development, if you see breast development tick 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 tick. But the most important difference is when we look at the axillary and pubic hair. In MRKH, axillary and pubic hair is well developed, it is plus, and androgen insensitivity, the axillary and pubic hair is absent, which is the answer, because it is androgen insensitivity. Remember, axillary and pubic hair are androgen dependent, clearly mentioned over here. So there is absence of axillary and pubic hair, therefore option C nahi hai, option D is the answer. Complete androgen insensitivity syndrome, also called as testicular feminization syndrome. Yes, you need to hear this lecture, TFS, very important. So in MRKH student, in MRKH or RMKH, axillary and pubic hair is going to be present, and here that axillary and pubic hair is going to be absent. That is how you differentiate. One more thing is that here they have got undescended testes, so they also can present with lump or inguinal hernia. They can have a lump in the inguinal region. Inguinal lump, that is the undescended testes. Okay, I hope that is absolutely crystal clear to all of you. So this is what. Now, do we have one more? Yes, this was one more just to clear the doubt. Again, I have got a 16-year-old girl, web neck, shield shaped chest, widely spaced nipple, very simple MCQ, streak ovaries noted on USG. What is it? Yes sir. So this was just to show you both primary one. This is now Turner syndrome, because in Turner syndrome you have got short stature, shield shaped chest, web neck and streak ovaries. But can anybody tell me what about the uterus? What about the uterus? Uterus, what happens to uterus in Turner syndrome? Yes, very good, Khan. Yes, all of you correct. So uterus is hypoplastic or underdeveloped, but never absent. Please keep this in mind. Uterus will always be present in Turner syndrome, but is never absent, because absent uterus and primary are only these two cases. These two cases the uterus is absent. Okay, Turner syndrome uterus is small, hypoplastic, but never absent. Okay, yes, not well developed. Okay, small hypoplastic uterus, because streak ovaries, there is no estrogen. Estrogen is not coming. Okay, yes, need to go ahead. Yes, very. Is it understood to all of you? Yes. Now again a very important topic, emergency contraception. When do we use it and what are the indications? And yeah, never absent. Yes. Okay, all of the following except, I think all of you are not reading the word except. Yes. Okay, so don't be in a hurry. When directly you read 5 days and you mark, it is 5 days except. Here please read except. Yes. So please understand students that anybody first, how does the emergency contraception act? So the emergency contraception is used for emergency backup, like if the condom tears, ideal the like boyfriend girlfriend meet, they have no plan of having sex but they'll end up having sex, or rupture or tear of condom, or there's a rape victim, then definitely we should give emergency contraception. What is its action? So these are called as interceptives. They may delay the ovulation and prevent the union. But anybody, what does interceptives mean? What's the meaning of interception? Interceptives means they make the uterus unsuitable for implantation. Implantation will not take place. Uterine implantation is very good, is going to get affected. I put a cross. Uterine implantation will not take place. That is how the emergency contraceptions act like. Okay, and most of the emergency contraceptions, when the emergency window is 72 hours. What is it? The famous, we are not supposed to remember the brand name, but I-pill. What is I-pill? I-pill is nothing but, what is I-pill? I-pill is a brand name, don't remember the name, but I-pill is nothing but a single tablet of LNG 1.5 milligram. This can be used only up to 72 hours. Okay, only up to 72 hours, and that is the answer over here, because here which of the following can be up to 5 days पूछा है. IUCD, yes, can be inserted up to 5 days, and this is something very new. Ulipristal 30 milligram single dose, both these are up to 5 days. Okay, so I hope this is absolutely understood to all of you, that IUCD, but LNG tablet, yes, LNG 1.5 milligram tablet is I-pill is up to 72 hours only. Okay, because after that it will not be effective. Here the question is, all of the following can be up to 5 days except. So except, so what is the answer? Except LNG. LNG 1.5 milligram. So this is allowed only up to 72 hours. Yes, perfect. Thank you all. Yes, so now moving on to the next question, and that is this: which of the following is an indication for surgical management of ectopic pregnancy? Yes, anybody? Surgical management. Yes, very good, all of you. Excellent, all of you. Yes, yes, all of you. Yes. So point number one, when I want to treatment of ectopic pregnancy, fallopian tube is the most common site in ectopic pregnancy. Anybody, what is the first preferred treatment for ectopic? Wherever possible, for ectopic pregnancy, we would like to give methotrexate. Methotrexate is the treatment of choice or the drug of choice. When I would like to give methotrexate, how do we give? Intramuscular route. Okay, intramuscular methotrexate. Okay, so we would want to go for medical treatment. Very good, Nikita. Methotrexate, all of you correct. So there are 4 conditions, but as a student remember first 3. Okay, so point number one is that the gestational sac, when I measure, it's called a G-sac, should be less than how much? 4 centimeters. Yes, some books say 3.5 centimeter, some say 4. let's keep it 4. So the gestational sac is less than 4 centimeter, very good. That means suppose it's a 2 centimeter, so this is good. Gestational sac 2 centimeter, go for methotrexate. Okay, then when I am giving, yes, why I have to monitor the HCG levels first? HCG levels should be less than 5000 micro international units per ml. Okay, so less than, because the levels are very high, 8000, 9000, 10,000, the HCG, it's a very big thing that it can rupture anytime and methotrexate will not work. So very good, that is the answer. Okay sir, beta HCG levels here it is given as 10,000. So the HCG level is 10,000. What am I going to do? Sir, I'll go for surgery and I will not give methotrexate. Methotrexate cross. Methotrexate cross. And definitely most important criteria is that methotrexate I can only give in a hemodynamic stable. Okay, the patient, that should be the first point. In fact, this should be the second point, this should be the third. Okay, hemodynamic stable patient, that means it's a unruptured ectopic. Unruptured ectopic, only think of methotrexate. Anybody, if it's a ruptured ectopic, I have to go for emergency surgery. Is understood all of you? Yes, and very good all of you. The fetal cardiac activity should preferably be absent. Preferably be absent. That is the answer. Okay, preferably, even if it's present you can give, but that. Okay, so absence of cardiac activity, very good. Again I can go for methotrexate, and hemodynamic stable patient, of course I would go for methotrexate. So the answer is option 2, that when the levels are 10,000 I would definitely go for surgical management. Okay, is it clear to all of you? Yes. Now we'll come to more points, time permitting, about this topic also. Yes, again a clinical question which is a popular among the, started coming in FMGE exams also. Okay, so I have got a patient who is having preeclampsia, 28 weeks. We have got history of headache, blurring of vision, oliguria. Is it danger? Yes. 160/100, cervix dilated. What is the next appropriate management? Can anybody come up with a diagnosis? What's the diagnosis of this patient? Just highlight all the important features. Preeclampsia patient, when they complain of severe headache, blurring of vision, oliguria. Preeclampsia से better, preeclampsia से better. Yes, eclampsia nahi beta. Medico VH, is there convulsion? No, there's no convulsion. There's no convulsion, so I can't call it eclampsia. It is definitely not eclampsia. Yes, hypertensive emergency, okay, 161. And what is it? Chalo, all of you my students, preeclampsia, yes, but this becomes severe preeclampsia. Very good, it becomes impending eclampsia. Can anybody tell me why am I calling it impending eclampsia? Very good, Vihari, Priyanka, Nahid, all of you. Abhi. Yes, this is because of this headache. So there are five dangerous symptoms. All of you should know this. What are the 5 dangerous symptoms? Sir, headache, oliguria, nausea, vomiting, epigastric pain, and blurring of vision. I'm writing short form, but all of you understand. I repeat, these 5, please by heart, these 5 are called the dangerous signs and symptoms. headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. These 5 tell me that this patient is now very dangerous. It is impending eclampsia. And then what do I do for impending eclampsia? Do I only start antihypertensive and go for LSCS? Never. Please understand, impending eclampsia is not an indication for LSCS. Yes, antihypertensive okay, but not direct LSCS. So I don't agree with this answer. Why will I not give tocolysis and wait? Why will I not do this? She's only 28 weeks. Yes or no? Please see the weeks. So can I wait? Yes, sir. Let me wait. She's only 28 weeks. Never. Why never? Never wait and watch in this situation. Why? Yes, sir. Because when there is this impending eclampsia, if you wait, the lady will get eclampsia and she can die. So it's a very dangerous condition. We have to save the baby. We cannot, if we try to save the baby, that's okay, but we have to save the mother first. Okay, means we should try to save the mother first. Baby, if it's saved, okay, otherwise it's okay. So you cannot give max self, agreed, but I cannot deliver at 37 weeks. Why? Because we are only 28 weeks. So from 28 weeks, if I try to wait till 37 weeks, mother will die for sure. Is it clear to all of you? So can anybody tell me what is the definitive treatment? Sir, whenever I am having impending eclampsia, delivery. All of you, delivery is the definitive treatment. Delivery is the definitive treatment, and therefore an immediate delivery, but I would like to give magnesium sulfate to prevent convulsion, antihypertensives of course I will give because BP is high, and then immediate termination of pregnancy. Option B is the answer. Is this understood to all of you? So don't wait and watch. This is a very important MCQ which has come in the past in NEET PG, likely for the FMGE exams also. So impending eclampsia, delivery is the definitive treatment. Max self would be given to prevent eclampsia, and then you go for immediate delivery. No, eclampsia and better eclampsia is pre-eclampsia toxemia. Yeah, you can say, but that's an old word. So impending eclampsia is better. Okay. Yes. Now this is again a very interesting question where they can ask you about the contraceptive method and the failure rate. So again, why I like this question, because in this 4 MCQs are asked to you. Okay, so let us start discussing. Male condom, what kind of a method it is? It's a barrier method. It's a barrier method of contraception, but it has a high failure rate of 4 to 14%. So one is going with D. So ये one is not A. A नहीं है, इतना कम नहीं है. So 1A. So this option, match the columns are also in a way easy. Okay. So first is gone. 1B could be, but not. Okay. Copper T or IUD, very effective method. 0.5 to 1.51% somewhere, copper T or IUCD. So 2 is A, very good. 1D, 2A. So even if you know 2, you know the answer. Okay, and LNG IUD is our Mirena, one of the most effective methods. LNG, yes, only 0.9 to 1%, 0.09 to 1% LNG IUD. So 3 is going with C. And diaphragm, yes, again very high, 18 to 25%. So 4 is B. So perfectly correct. 1D, 2A, 3C, 4B, and therefore option B is the answer. Okay, is this understood to all of you? Okay, so LNG IUD 0.09 to only 0.1% is the failure rate. and it causes a progesterone induced amenorrhea. Can anybody quickly tell me what are the other benefits of LNG IUD? Tell me 3 conditions where I can use LNG IUD. Uses apart from contraception. Which cancer will it prevent? A PID decrease, okay, yes, but more commonly, correct, I agree with you, Vihari, but where do I use it? For which patients? No, not for PCOD. Endometriosis, excellent, very good. Endometriosis, very good. So I can use it for menorrhagia, heavy menstrual bleeding. It is one of the treatments for menorrhagia. I can prevent the hysterectomy. Menorrhagia, very good. Endometriosis, agreed. And it will also decrease CA endometrium and also endometrial hyperplasia, very good. And I can use it in endometriosis also, perfectly correct. And yes, to decrease the size of the fibroid, excellent. So these are all very, very important MCQs. So I hope this session we are not only discussing one question, lots of other questions regarding one topic also we discuss. Okay, I've got still some time for this. Yes, can anybody, this is the ultrasonography of the uterus. What is it showing? What is the diagnosis and what is the management? Very good student. This is, if you see inside the uterus, they are multiple fluid filled grapes like vesicle. So this is our famous snowstorm appearance. Snowstorm appearance is suggestive of vesicular mole or hydatiform mole. Okay, so this is snowstorm appearance, and of course we never do LSCS, we only OC will not going to help you out, and I should never do induction of labor. Why? Because it's not a well formed. What happens if I do induction? So the treatment, absolutely correct, it is suction evacuation, and it's a vesicular mole. I have to go for suction evacuation. Why? Okay, why? Because never induce labor. What will happen if I induce labor? So this is the uterus. There are multiple grapes like particle. If I make the uterus contract, what will happen is that some grapes like particle will come out and some will remain inside. So therefore induction of labor should never be done, and we always go for suction evacuation, or also we call it a dilatation and evacuation. And after sucking out the pregnancy, what do I monitor? Anybody? What should happen? What investigation should we do? This also asked in last year's FMGE exam. We have to monitor what? We have to monitor the HCG levels. HCG should keep on, yeah, histopath we definitely send the products to, agree, but HCG blood test should be done repeatedly. It should keep on decreasing to make sure that it is completely clear and there is no malignant transformation. Okay. So snowstorm appearance, ultrasonography uterus. Yes, again a simple MCQ. I skipped the previous because we discussed it last time. Yes, Osiander sign means what? Again a popular MCQ for the FMG. Anybody? Yes, so very good. No, not B, Q chala gaya. Okay, Osiander sign is the pulsations in the lateral fornix, which is the pulsations you get in the lateral fornices, which is of the uterine artery. Okay, yeah. Bluish vaginal discoloration is our Jacquemer, Jacquumier, or also called as Chadwick sign. Okay, Chadwick. Cervical softening is the Goodell sign. Goodell. Okay, and on bimanual examination, number of fingers, Hagar's sign. Okay, so this is just you might have to mug up these questions, but they ask you this, and you need to know this. So Osiander sign is pulsational lateral fornix seen in early pregnancy. You can also see it in acute PID, by the way. Okay, acute PID also is mainly seen in pregnancy, and PID, it is the pulsations of the uterine artery. Yes, and we would like to show you one HSG, very simple, but it was asked in the past FMGE examination. What kind of a uterus, what is it? So if you know the normal HSG, always remember students that the normal HSG, the uterus is triangle. Uterus is triangle. This is with a cannula, and then I see one tube, I see another tube, and we see the spill of the dye. It's a test for tubal patency. Now here what is being seen is only one side of the uterus, isn't it? All of you please pay attention. Okay, we are seeing only, of course, one tube, so we are seeing only one half. This is, therefore this is not a yes, so it's like a banana shaped uterus, or this is not a normal HSG. What is Asherman syndrome? Sir, Asherman syndrome is multiple intrauterine adhesions. So we would see like this. Asherman syndrome is multiple filling defects. Okay, multiple filling defects we would get in Asherman syndrome. Bicornuate, of course, I'll show them in two horns, and it's not a cornual block. Cornual block nahi hai, you can see, and it's not bilateral. You can see the tube. So this is a unicornuate uterus. Only one horn is seen, also called the banana shaped uterus or unicornuate uterus. Okay, and we would like to finish the discussion on this also, that what is this picture now. Okay, probably the last question for the day. 15, yes. So what kind of this is there? Okay, so I showed you both unicornuate and what is this? Okay, AB. Okay, so now please pay attention, not unicornuate. Now how is this? Your radiology teacher will also teach you this, because I've taken combined classes with her. We have discussed that also. What you need to keep in mind, of course, difficult, it's not 100% accurate with HSG. We need a laparoscopy to confirm, and hysterolaparoscopy is confirmatory HL-scopy. But what happens is that when I see two separate horns, which are wide apart, so either we need to, when we see two things, either it's a septate uterus or a bicornuate, all of you know we have to choose between A and B. When there are two horns which are wide apart, that means the angle between them is a obtuse angle. Then what it is, or if all of you tell me, if this is the uterus, the septum coming inside, there's a septum, isn't it? Septum is within the cavity. So now if I push the die, what will happen? All of you can tell me. Sir, if I push the die, and this is just highlighting that this all will get opacified, this part will get opacified. Okay, So what we are going to see is we are going to see like this, the two horns which are closer by. So yes, so when the angle is obtuse, we call it as bicornuate, and when it is acute, we call it as septate uterus. In septate uterus, the two horns are going to be closer, it's acute angle. And this picture, definitely this is like this and this is like this. Yes, I can understand that it might not the best thing to ask in the exam, but this I would like to go because this is a acute angle, and therefore I will mark septate uterus as the answer rather than this. Okay, and septate uterus, remember students, hysteroscopy is the treatment of choice. Okay, hysteroscopy, and hysteroscopy is to be done, and hysteroscopic septal resection is to be done for septate uterus. So I repeat, when it's two horns, single horn is our unicornuate, and two horns wide apart bicornuate, two horns close by septate uterus, acute obtuse. Okay, so I hope all of you had a great time today. So many MCQs we discussed and I had a great fun, and all of you please share this video also with your friends. Do leave some words of appreciation in the comment. Also download the Unacademy app. Do not forget to follow, and we are having fabulous sessions for NEET PG paper also started. Mentor is the code to get the discounts. Do not forget to check out the videos of NEET PG Vitals. Absolutely important pre-recorded lectures. They are super lectures which will really help you. And lots of students have got the benefit, and all of you, June 21st, this is the next batch which has started, and also for FMG, and I want all of you to give the All India medical test for FMG, which is on 25th of June. 25th of June, all of you can give the exam. I thank you very much students for coming in today. I hope all of you had a great time today. Bye bye, best of luck, see you, and see you tomorrow at 2 o'clock in the plus class. Tomorrow 2 to 4 plus class, very important. Join in me for the next preparation. Bye bye, best of